So again, welcome to this webinar on crisis services across the continuum of care, offered to you today by NAMI Greater Cleveland. NAMI Greater Cleveland is a grassroots organization that was founded in 1979 in Wisconsin by a group of mothers of children with mental illness, specifically schizophrenia. And they started this grassroots coalition of the National Alliance on Mental Illness because they were dissatisfied with the lack of support and education in society and in their communities around the topic of mental illness. NAMI is now the largest grassroots mental health organization of its kind and is represented by state and local affiliates in all 50 states and Washington, D.C. and Puerto Rico. NAMI Greater Cleveland is the local NAMI affiliate that serves Cuyahoga County, and our mission is dedicated to empowering those living with mental illness and their family members to achieve a better quality of life by providing education, support, information, and referral and advocacy. We offer support groups and educational courses for people living with mental illness and their families. And we also do community education on various topics like this. We have a helpline that is available Monday through Friday, 9 a.m. to 5 p.m., where folks can call in and just ask for referral or information about mental health treatment options locally, other community resource and community services locally. And we also support advocacy in the sense of raising greater awareness about mental illness, reducing the stigma around mental illness, and supporting state and national legislative efforts related to mental health, increasing funding for mental health services, promoting greater access, reducing disparities in mental health, and just really contributing to a grassroots movement that is all about ending the silence and promoting greater conversation about the topic of mental health. So we're very excited to have our two presenters here today to talk about this topic. Since we do have quite a few people on this call, I do ask that if you have any questions during the webinar, please put those in the chat. I will be monitoring the chat. We should have a little bit of time at the end of the hour for Q&A, but if there is something particularly pertinent that we see in the chat, we will address that during the presentation. So feel free to take advantage of that resource while we're doing this presentation. We want this to be as useful for you as possible. And again, it's being recorded so that it will be made available on the NAMI Greater Cleveland YouTube channel at a later date, probably within the next few days. So with that being said, I think I will hand things over to Michael and Jane to introduce themselves and get us started. Thank you so much.
Thanks, Matt. Go ahead, Dr. Pescaro.
Yeah, hello everybody. I'm Dr. Mike Pescaro. I work at St. Vincent Charity Medical Center. I'm a clinical psychologist by training. I'm also board certified in forensic psychology. Worked in the community for a long time. Been a part of St. Vincent since January of 2020. Prior to that, worked at the VA healthcare system for a good number of years. Been all over the place, and I'm really happy to be here and talk with you about crisis services and discuss with you what you think we need and what some of the gaps are in our community.
And I'm Jane Granzier. I'm so glad you're all here today, and I thank NAMI for inviting us to speak with you. NAMI is a resource that we at Mobile Crisis, as I'm sure St. Vincent's does frequently, provides to family members, loved ones, and clients themselves for the really free service delivery and options for more opportunities for education and partnering with other people who've walked the walk in terms of having a loved one being involved in a system that is not always as friendly as we'd like it to be. And that's really part of, the feedback that we want to give and provide time for later on today to get your feedback, good and bad, right? Because that's how we sometimes learn from experiences that didn't go as best we expected them to. So we're going to go ahead and Mike, if you want to advance for me. I should say I'm the Associate Director of the Crisis Service, and I've been here 25 years and in the Crisis Service the entire time. And prior to that, I worked for 3 years between being an intern and being an employee at St. Vincent Charity. So sort of one-stop shopping in terms of my experience. We're going to talk about St. V's and how to utilize their services when they can be most appropriately utilized and effective for yourself or a loved one. We're going to talk about mobile crisis team, specifically our outreach service on the adult team or the child's, as specifically dedicated crisis workers working with children and adults, as well as our Crisis Stabilization Unit, 24/7, 365. And then we are going to provide time for questions. So, and as Matt indicated, please put your questions in the chat so we all know if you have the question, someone else does as well. We'll go ahead and advance it if you would. So I'm preaching to the choir, I'm quite certain, between other providers who are joining us today. And I saw a number that I've had contact with in the past, as well as advocates and individuals living with mental illness. So, this is in 2018, they did this study in Cuyahoga County, and I'm sure we have perhaps people outside the county possibly online, but this is specifically for Cuyahoga, that at any given time, there were 62,000 adults dealing with mental illness who had received no treatment whatsoever. In terms of youth, yeah. In terms of youth, it was 5,600.
I mean, yes. Oh, shoot.
We're not able to access treatment, even though they were symptomatic and having a major depressive disorder episode, right? And we know that, especially in terms of youth as well as adults, with the impact of the pandemic and some other issues that go along with that, we've seen an increase in some of those numbers. And that, and this isn't probably, I would say, an underreporting, that 2% at any given time of our adult population in our county, almost 18,000, were dealing concurrently with both substance abuse issues, some substance use disorder, and mental illness. And again, probably an underreporting. The other piece that I think is pertinent and is timely, it's always pertinent, but it's become more timely in the last couple of years, although it's something many of us have dealt with in mental health and understood the impact of for quite a while, is that at any given time in Cleveland, for the Cleveland Division of Police, 35 to 40% of the calls that come through 911 have some mental health component to them. And there is an ongoing effort of all providers and entities in the crisis and emergency response system to see how we can reduce the number of calls to 911 and direct them instead to individuals who primarily deal with mental health. Just as an aside, there is going to be a transition in July of next year, 22, that all calls, the National Suicide Prevention number, the 1-800-273-TALK number, is going to be transitioning to 988, which means that, similar to other sorts of emergencies, that's going to be a dedicated mental health emergency line. And we're hoping that's going to make some, help us better respond and get people into the right place that they need to be. You can go ahead and advance it. So try as we might, sometimes we're pretty successful and sometimes we struggle. St. Vincent's and mobile crisis end up being sort of the safety net beyond law enforcement. We know law enforcement is not everybody's first choice. They are, though, still, as we know, getting the majority of the calls initially, and do have the capacity, the way they're staffed, to respond in a more timely way. We prioritize, at least in mobile crisis, our priority are individuals who are in the community who are not linked at all to any service providers and have no sort of organic support with them. And beyond that, we know that even for individuals who are actively linked with a community mental health center or a private provider, after hours and on the weekends, sometimes it's very difficult to get a hold of your provider. Continuity of care is an issue. You want to be working with the person who knows you best. But in lieu of that, without having access, then we do become the provider. And many of the clients we see, whether they get routed through mobile crisis or whether they get picked up by the police or bring themselves in, are also seen at St. Vincent Charity in those hours. Next, and I think it's...
Yep, I think I take over at this point. Yeah, thanks, Jane. Good overview. I think, I'd really like to begin the conversation just by talking a little bit about St. Vincent Charity Medical Center for those of you that don't know a whole lot about us. It's important to know that the Sisters of Charity of St. Augustine have been in the business of caring for people for the last 170 years. Been around for a long time, really dedicating, their lives to the healing ministry of Jesus, which is simply, helping, respecting, valuing, and providing care for all of God's people, everybody on this call and in this community. Our services are for everyone. Our commitment, it really is to providing quality service, educating future health care professionals. For those of you that don't know, we have a pretty large GME or graduate medical education program here for internal medicine. You can really feel the passion, the commitment as you walk through these halls. It's pretty palpable here. I wanted to also just talk a little bit about our services. We've always offered a really solid continuum of acute care services here at St. Vincent's. And as recently as the first of the year, historic for us, actually, we started offering outpatient mental health services. Really right now, we can meet an individual needs when they're in acute psychiatric crisis through our psychiatric emergency department. I'll talk a little bit more about that in the following slides. That's the bulk of what I'm talking about today. But I wanted to give everybody an overview of really what's available here, because it's quite a bit. So again, somebody's coming through an acute crisis, they can go through the psych emergency department, but they can also go through Rosary Hall inpatient, which is our detox unit. They can then move on to intensive outpatient treatment at outpatient Rosary Hall. We can provide medication assisted treatment to individuals. And now we have outpatient mental health, trauma, and wellness services through our new integrated care clinic across the street. So that's everything that we offer here. Obviously, Jane already touched on some of this, but our psychiatric emergency department is the safety net service here. It's a locked unit, secure. It's staffed by a multidisciplinary team of psychiatrists, nurse practitioners, nurses, social workers, mental health technicians, and security officers. We provide services for nearly 50 municipalities. It is obviously for those folks who are at imminent risk of wanting to harm themselves or others. Individuals that come through our psych emergency department tend to be pretty acutely ill, meaning they're very agitated, psychotic, manic, or under the influence of a particular substance. They're really unable to care for themselves. And what we're going to do here for an individual is provide that evaluation, that triage, that initial stabilization and treatment, and observe folks for a period of time to make sure that either one, they're okay to go home, or move on to jail or wherever they're going, or they get admitted to one of our units or are transferred to North Coast. We work with the mobile crisis team to provide second opinions. So they'll go out and see somebody who's uninsured at one of the local ERs. And if it's an uninsured person, they'll make a determination, get them over here. We obviously look at them and then they go to North Coast. Obviously our psych emergency department is also providing connection to outpatient services, whether people are not connected or need to be reconnected to their outpatient provider. Referrals come from all over the place, but really our strongest user of services here are the police. We get about 3,500 to 4,000 visits a year here, and about 50% of those come from the Cleveland Police Department in outlying municipalities. The next, obviously, user of services are the other first responders, EMS and fire, and then obviously people themselves, what we call self-referral. So people walking into our emergency department or finding their way here some way or another. The leading disposition, or where people go when they leave here, followed by our hospital, people are going back home, back to community mental health, or like I said, they're being hospitalized here. We admit about 25% of the people that come through the emergency department, the psych emergency department here. I look at that as a good thing. That means we're really trying to make sure that people who get admitted, at least here, really need to be admitted. I think we can probably also talk a little bit though about just what's needed. We oftentimes have people who come here, they don't necessarily meet the need of a hospital level of service. And so they end up getting discharged back to the community, and then they come back and the police are bringing them back. And we've had a lot of interesting conversations since I've been here with police and with the community about, well, and really what this is boiling down to, folks, is there's just not enough. There's not enough for folks. We can take, there is a crisis, in our community, a mental health crisis in our community, and we really need to think about different ways to respond to it. I'm really kind of hopeful at the end of this we'll have time to talk about what are some of the things that we can do as a community to solve this problem, because you know what, the hospitals aren't going to do it, the police aren't going to do it. We're all going to have to come together to try to figure out how to best meet individuals' needs, when they need it most. And I'll finish up with obviously referrals. So obviously an evaluation can occur at our psychiatric emergency department if people are just walking in. They're being transported by first responders or law enforcement. And then of course, we do have a centralized intake number, which I listed here, and that gets you access to not only primarily for the public, that's going to get you access to our outpatient services like Rosary Hall and outpatient mental health. And Jane, I'm going to turn it over to you.
Pass it over. All right, you can go ahead and advance one screen, please. So mobile crisis team is embedded in Frontline Service, which is one of the several community mental health centers in Cuyahoga County. Just to give you a little bit of history, we're located at 18th and Payne, the 1744 Payne downtown. Our agency started off serving primarily the homeless mentally ill, and today we have the largest continuum of care for the homeless mentally ill in the state of Ohio. In 1995, our crisis services started, comprised solely of the 24/7, 365 suicide prevention hotline. And then a couple years later, in 97, we were doing crisis outreach then at that point as well to adults. In 97, we added 2 other components, namely crisis outreach to children and adolescents in the county, as well as the gatekeeping responsibility for North Coast Behavioral Health, i.e. anybody who presents and is evaluated in one of the 22 different emergency departments in our county who have no insurance whatsoever are evaluated first by somebody at that particular emergency department, and then a pink slip is typically written, and then they call mobile crisis to do an independent assessment. Our role is primarily to ensure that the least restrictive philosophy is being followed, i.e. if somebody does not need to be in the hospital, we're looking at our less restrictive alternative options. Our Crisis Stabilization Unit, can we get them in to see one of our psychiatrists? Our service in terms of our outreach is to provide a timely crisis response, which given our current situation and really even when we're completely fully staffed, which you might have heard is a challenge for a lot of places these days. It's not unique to us in crisis, but it is a reality. We're providing same day response to someone's crisis. If a family member or loved one is calling, or a client themselves, if they're in an immediate or acute imminent situation where they are potentially a danger to themselves primarily, and less commonly a danger to others, typically because their judgment and insight is impaired because of their chronic and persistent mental illness, like a schizophrenia or a very vegetative depressive episode. In those situations, we do need to sometimes rely on alternative resources. Can a family member get you to an emergency room? Can someone come over and stay with you until our team can get there? We want to try to build up a safety plan until we get involved. But I think our services work best when somebody is starting to become symptomatic before they become so impaired that their judgment and insight is really, it's not conducive to their safety or the safety of others. In those cases, we're still appropriate to call. We'll come out and help facilitate evaluating somebody, and then we'll go to probate court if need be. We are happy to play that role when we can, in lieu of family members having to do that. We understand that's a specific spot for us in the community, taking that responsibility off of family members, because it can be complicated in many ways, we know. Ideally, getting there before the police have to be there. That's how we see our role. Next. Thanks. We serve anybody in Cuyahoga County experiencing a developing or active crisis, child, adolescent, adult. Insurance, capacity to pay, our services are totally free. We serve everybody. There is no, the only criterion we look at is around your current symptoms and what our capacity is. That's how it comes down. The only time insurance is ever even a consideration is, say, for example, if a hospital calls us to come out and provide that gatekeeping responsibility for adults to North Coast, and we're able to establish, usually because we have history with the individual, or because we can look up, check their Medicaid status at that moment and verify they have active insurance, or we're able to call their loved one and verify they still have, COBRA from when they left their job. And really what that does is it helps facilitate that individual having a choice in hospitalization, usually being admitted, a choice to a degree, either the Cleveland Clinic, UH, or Metro, one of their behavioral health units. And as I indicated earlier, if we have competing demands and we're having to sort of prioritize or triage who we're responding to first, we're always going to try to get out to the individual in the community first versus hospitals. Hospitals, we know, we want to be responsive to them as well. We don't want people to languish in emergency rooms, but they do have staff there. They do have security there to help if somebody becomes exceedingly escalated. We want to go out into the community to individuals who don't really have any support at all. Next. And we do have a number of services. So I always indicate that we're not just the suicide prevention hotline for Cuyahoga County, an arm of the National Suicide Prevention Lifeline, but that we're also the mental health referral and information and mental health and substance use disorder referral and information line for the county. I'd love to say our staff is perfect. They're about as perfect as I am, which is not perfect, but nothing sort of gets me frustrated if I'm sitting in my office and I hear our staff, and usually it's a combination of either compassion fatigue on their end or just being reminded of what our role is. People don't have to be in immediate crisis to call us. You can call and ask any question at any time. If we are having a lot of competing calls on our hotline, most people are very reasonable. If we say, I apologize, but we've got to be responsive. Can I take your number and can we call you back within the next hour or a couple of hours? People are appreciative of that. But we are here to listen. We do some brief counseling. It's not our primary role, but do we end up doing that? Yes, we do. We ask some questions and try to sort of collaborate with the caller about recommendations on next levels of care. That might include our offering to come out to someone's home to do an assessment for the person they're concerned about or the client themselves. We have, as I indicated, both specific adult crisis workers and child adolescent crisis workers. When we come into people's homes, we always go 2 by 2, as opposed to going out to hospitals or say even schools for children and adolescents. We'll just send one crisis worker there. We also, our agency runs the Crisis Stabilization Unit for adults at 8315 Detroit Avenue. We also are the gatekeeper for the crisis stabilization beds for children and adolescents, which are housed respectively between Belfair, Guidestone, and Applewood. Sorry, I'm not good at multitasking. You think I would be, but I'm reading the comment and the question at the same time, which I'll address. And we also, this is the second iteration currently. I'm also responsible for the 3 crisis police co-responders who are embedded in 1st, 2nd, and 3rd District of the Cleveland Division of Police. This is our second pilot. Another one ran from 2015 to 2018. It was stopped, and then it restarted again in 2020. And we have another year on the pilot. And I'm hoping that gets continued because I think any effort we can make to work more collaboratively with other providers who are responding, so that we can, sort of impart our unique knowledge base to one another to get the best response for the individuals is helpful. We provide a follow-up service by phone and by mail with individuals recently released from an inpatient behavioral health unit or having been seen in an emergency room and discharged, where in both of those cases, suicidality was one of the presenting issues. We know that there's a really significant increased risk for suicide in the first week post-discharge from a hospital. It's 300% increase still right? And 200% for the remaining 3 weeks of that first month post-discharge. And that's our effort to ensure that individuals being released from any facility across the county receive that contact. We know many of them are released with follow-up outpatient appointments or psychiatric appointments, but that's a pretty time-sensitive, period where we really want to make sure people have the support they need. And then we also are involved in crisis chat services. Next. So I'm not gonna, I know that I'm assuming, Matt, that people who are participating today will receive a copy of our PowerPoint, right? So, I share this slide with you, namely to say that sometimes when folks call, and we understand they're calling because they are in crisis or their loved one is in crisis and they would like an answer post haste as to what to do. Are you coming out? Are you calling, will you help me call the police? Whatever. There are some questions we do try to answer, some questions we need answered before we can make a determination. So I simply listed here, obviously demographics, although I will step back for a moment and say anyone can call our line and they don't have to share their name, right? They don't have to share their name. They don't have to share their number. Might we pick it up off of our call our phone system? We might, but that's not a requirement to receive our services. However, if we're trying to facilitate a response in a timely way, we might ask what's going on with the individual. We might ask a bit about their prior mental health or substance use history, whether they've had treatment in the past. We might ask about family history. We might ask, and yes, to the chat question said, will we do a suicide risk assessment or screening on the phone with adolescents? We're affiliated with the National Suicide Prevention Lifeline, and we are required to do that with every caller to the highest degree possible, right? To ask not just about ideation, intent, plan, but to gather additional information about prior history, if those are endorsed. If somebody's saying that in this moment in time, they are having those thoughts, we know there's a massive continuum around suicidality in terms of thoughts and action, right? But we try to be the alternative to a lot of individuals in community because of the very stigma that NAMI works so tirelessly to drive down, that a lot of folks become sort of immobilized when somebody says they're suicidal, right? About how to respond to them. And sometimes people fall back on that, well, we have to call the police. And, if somebody is imminently suicidal, has been looking for means, has procured the means, and has the means in hand, then ideally, maybe you do need to call the police, but we still at Mobile Crisis will talk to that individual and talk to them about putting their means down and putting them in a different room and, engaging them around, is someone else at home with you? Do they know how you're feeling? What can we do? The whole idea in Mobile Crisis, if we're working, the way we should be, is that any phone call is going to try to help us ensure that individual's safety for the moment, right? We can't control the future, but we can talk about right now. Moreover, we're working to simultaneously do that while we build rapport with that caller or that loved one so that they'll reach out to us again in the future. If we breach that opportunity to join with that person and gather enough information and they don't call us again in the future, that means that essentially one of the sort of fail-safe resources in the community has been taken from them. And that's really not what we want to do. We want to try to gather information. So thanks for your patience when we ask these questions. It's helping us determine the best next steps. You can go to the next screen. So I know, can everybody see that okay? Should I make it larger? That's Mobile Crisis Team's number. Some of you have it already. Some of you have it committed to memory. We are here 24/7, 365. Holidays, every day of the week, every day of the year, we're here. A little bit, something that makes us slightly different than many of the call centers and crisis teams across the country is we have a 24/7 supervisor on site at all times. Our staff, our supervisors are not on call. They're here with our staff and helping up to pick up the phones and during high volume call times. And so that consultation is real time. that you're speaking with an individual. And if you've called us in the past, you may recall that sometimes we'll say, okay, I think I've gathered the information I need. Can you hold just a moment while I consult with my supervisor? That is, sort of not a typical counselor, social worker training where we share the responsibility of making the decision-making about what happens going forward. So what I would simply say is, if you run into a situation where you're calling about yourself or someone else, and you feel that the response you're getting is not consistent with what you think would be or what we're talking about today might be what you could expect from us, simply ask to speak to the clinical supervisor. Mobile crisis team, our staff, we kind of have them do that at other places too. It's not because we don't think the person we're dealing with is capable or that we're trying to one-up them. It's merely so that we can all be communicating in real time, gathering the best information about how to best help the individual we're all working with. Next. Okay, so we respond, as I indicated before, I won't belabor, emergency, if somebody's already ingested. We had a call yesterday from a parent whose adolescent had ingested a certain number of Tylenol. That's not something where we're going to have them wait for us to come out, obviously. That's where we're going to talk about either that parent's capacity to immediately convey them to an emergency room so that they can get lab work done, right? Or if we think the amount is so significant, we're not going to ask the parent to bear that responsibility. It's not ideal, but we're going to say we'd really like to call police and have EMS come and convey, right? So that's a situation where we would defer to emergency providers. If somebody's in a situation where their loved one, and we've had this, this is a great example, a family member called of an individual who was Black or brown and said, I don't want the police. This is not uncommon to come through mobile crisis. I don't want the police. And we understand as best we can, right? That impetus. We understand, like, what can you do for me? Let's keep the police out of it. And what I have trained our staff, and what we all trained our staff to say, is I will do that to the highest degree possible. I can't promise that to you until I understand what we're dealing with, what's happening. This was an individual who was high on PCP and was on top of his roof of a 3-story house. That's, again, it breaks your heart because I can, I want to honor the fact that when people call mobile crisis team and ask for our assistance, they are taking a leap of faith, asking somebody who does not know their loved one or their family to come out and provide empathic, trauma-informed care to help facilitate next steps. And there are times that simply the service delivery model is not what we can do in crisis. Having said that, we try to the highest degree possible to either meet the police at the residence, if we can send some staff out to meet the police there, which sometimes really helps mitigate some of those concerns. I'm not going to say it's going to solve everything, but it's an effort towards that end. The other option is we could say, let's call together to 911. We'll request a CIT officer respond if they're available, crisis intervention team trained officer with a minimum of 40 hours of additional training around mental health and engagement and, working towards not having to use any use of force, right? And yes, our capacity to respond is unfortunately impacted by our staffing at any given time. Your request might be absolutely 100% in our wheelhouse, something we would respond to. However, our program managers are balancing having people to answer the hotline so that we have a minimum number of staff in the room to be able to manage the 24/7, 365 hotline and mental health line, as well as being responsive in the community. And if we already have teams out at that juncture, no matter if yours was, the prioritization, it was higher, but if our team is already dispatched, then it can be challenging. So that's where it ebbs and flows and what you can sometimes expect in terms of our responsiveness. And I just wanted to, clarify that. Next. Our Crisis Stabilization Unit. You can access the Crisis Stabilization Unit myriad ways. Most frequently, referrals come to them through hospital step-downs from behavioral health units. I can talk about school-based assessments. Yes, Rebecca, help me remember, Matt, if you would. So The Crisis Stabilization Unit is a 24/7, 365 facility, average length of stay, anywhere from 5 to 7 days. It can spend longer, it can be shorter. There are our psychiatrist, Dr. Goldenberg, is there every Monday, Wednesday, and Friday. When he's not there, the unit is run by social workers and nurses. It provides individuals who do not require a locked unit, essentially, who do not require the highest level of care, the opportunity to be in a supportive environment that is not the community, but close enough to the community to restart medication, to have their medication evaluated and perhaps adjusted. For individuals who, regardless of their compliance, right? We know that in the mental health community, people get a bad rap, oh, they don't take their medicines. Well, psychotropics are no different than every other type of medicine. People can be as compliant as the day is long, and they're still going to have breakthrough symptoms at times. Their medication might plateau. They might need, simply there's a stressor in their environment, maybe a loss of some sort, or maybe a move, or something that's triggered their normal functioning. The crisis unit is a really nice alternative for those who don't want to be in a locked unit, who don't want to be in the hospital, have had perhaps less than positive experiences with that for whatever reason. I always say I love the crisis unit as an option when we're evaluating folks, because we know that one of the multiple stressors that contribute to the experience of suicidality is financial stress. And many of our folks that we see across the county don't have lovely benefits that if they don't go to work, their job can be maintained for a period of time. So the crisis unit, if somebody can participate in that level of care, it's a really nice option, because after the individual is assessed by Dr. Goldenberg, Monday, Wednesday, or Friday, he can give them the go ahead to go to work, right? So that the unit just knows they're leaving at this time during the day and they're going to be back at this time. There is like a evening check-in time. They like staff, individuals to be back by 9 o'clock, I think. The caveat and the individual who is the best fit for the adult crisis unit is somebody who can be symptomatic. They can be having auditory hallucinations. They can be suicidal. However, their symptom impairment is not to the degree that they don't have enough insight that this is part of my illness and it's disruptive and upsetting. And before I act on the thoughts, or before I act on these, whether it's command hallucinations or whatnot, I'm going to go talk to that lady, the social worker at the front desk, or I'm going to bring it up in the group they're going to have every day. Individuals who can reach out and ask for help, who have a little bit of insight that they're having some breakthrough symptoms. The other piece is that we do ask for individuals to come over who are willing to take medication. And we know that's not everybody. We know sometimes your insight and judgment becomes so impaired that you don't believe you need medication. So that's, I did not include, I didn't use my font 32. The number to call the Crisis Stabilization Unit is 216-651-9950. So hospital step downs, mobile crisis, and other community mental health centers are the primary referral sources, but there's nothing, thank you, Matt, there's nothing to stop individuals from calling themselves and saying, do you have a female bed available right now? I'm wondering if I could come over. And they will do a brief screening with you on the phone. Mobile crisis team can also facilitate that via screening or after we do a face-to-face assessment with you. Next. So very briefly, the things we do to leave time for questions: we help individuals who are completely fine to stay in the community after we see them face-to-face. We relink them with their current provider and let that provider know what's happened, provided the individual signs a release of information to allow us to do so for continuity of care. We might, if that individual is unlinked with any provider but is willing to come in and see one of our psychiatrists, the beauty of the Adams Board funding for our program is that we can sometimes get people in within 3 days, sometimes very rarely, but sometimes same day in front of one of our psychiatrists to sort of address and get a second opinion about level of care need, about whether or not somebody needs to be in the hospital or the crisis unit, or whether we can engage them on a community basis to start medication while we link them up with an ongoing provider. Lastly, we can recommend, as you know, as I've said, the Crisis Stabilization Unit. Obviously, the person has to be willing to go there and meet the criteria we just discussed, or is an absolute last resort, because we feel like somebody's judgment and insight is to the degree that it's so impaired that maybe some medication is indicated to help them restabilize for their safety and the safety of those around them, would be to facilitate an admission to the hospital. So I know there's some really good questions out there, and I think at this juncture, we wanted to, should we do the chat questions first while everybody reads?
Yeah, let's, can you address, Jane, the question about school-based assessments?
Sure. So on the child adolescent team, the child response team, we call it, 50% of the referrals come to us through school systems, and the other 50% are some combination of family members, parent, guardian, as well as sometimes other providers as the gatekeepers for the crisis unit. When a school calls us and requests an assessment, we always try to facilitate our response to the school system after having either ensured that the school is called the parent guardian and receive their buy-in, and that they are going to come and meet us at the school, so that we have the opportunity to interview not just the child adolescent, but then to also speak with the parent guardian about what their perspective of the statement or the child's presentation is, gather necessary history that, depending on the age of the child, they may not have access to. I would love to say that we're not seeing younger and younger kids every year, but those of you who do the work are not surprised by the fact that we are. It's not atypical at all for us to get calls on 5-year-olds and 6-year-olds who are articulating thoughts to harm themselves, etc. Our goal is always to go out and work, as we do with the adults, to evaluate and interview all the pertinent parties, the school system, what they're seeing, the child, the parent guardian system, possibly calling any current providers if we can reach them in real time to get their feedback, and then to meet again, typically with the system together, the parent, child, adolescent dyad together, to make our recommendations about what level of care we think is indicated based on the presentation. If you have a different question or a more specific question, please type it in. There was another question. Do you remember what it was, Matt, that came through?
Looks like we got through all the questions.
Yeah.
There was a comment, which I think is an interesting one from Carrie.
I see it. About, hi, Carrie.
Yeah, where she talks about placing people in the CSU, right, when they're coming out of hospital or jail, and the need to have more facilities like this. And I think that would be a good jumping off point. I mean, so for people that on this call that don't know, I said St. Vincent has, been doing what we've been doing for a long time with COVID, just with the problems that we've had, right? Mental health, behavioral health is such an incredible need. Our health system, so the Sisters of Charity Health System and the Sisters of Charity Foundation recently partnered with a global design firm called Mass Design to really look at our campus here and look at our grounds and look at the community to try to figure out what's needed. What can we do more to kind of address the community needs? So we're looking at this health campus initiative to where we can expand services. And one of the things I think in the work that Mass has been doing, working with community and doing community engagement and talking to a lot of people, we hear so much about the need. Right, the Crisis Stabilization Unit, it's 15 beds, actually only 8 now because of COVID. And that's really it. In our community for folks, for adults who need that level of service. And so that's kind of like how I had led led this meeting. Like, we know more is needed, but I would just be really interested. But Jan, I don't know what you think. I'd be really interested in what the folks on this call have to say about where can we improve. Certainly, we know, but where can we improve specifically in this area of crisis management? But not just I mean, look, at the end of the day, I would rather us prevent that from even happening. So what do we need to even do that? How can we really prevent crisis? What can we do as far as outreach goes? Jane, I heard you say a lot of times you're balancing staff. You know, do I have enough staff for the call line? Do I have enough staff to respond? So clearly more people need to be kind of doing this and helping out. How do we do that as a community? Because we're not going to solve this as just Frontline or St. Vincent's or whomever. It's going to be all of us coming together to figure this thing out. So I'll be quiet.
We just got a question in the chat from Joseph. What is the first step for a parent of an adult with schizoaffective disorder that is developing into a crisis, but they insist they are not going into crisis?
I would encourage you to call us at Mobile Crisis, and I don't know if you have already, Joseph, but letting us know the signs and symptoms you're seeing helps us gauge. You know, it's always difficult when a client is unwilling to accept, you know, intervention because they don't think they have a problem, which is part and parcel of all aspects of schizophrenia, we know, but not exclusive to. It's about sometimes bringing an outsider in and allowing us to at least try to engage or lay eyes on your son, because we're always looking at, you know, not just the statements, but we're looking at activities of daily living, right? We're looking at his capacity. How is he bathing? Is he doing things that place him or others in the home in harm's way unwittingly, like smoking and ashing on the bedspread so that, you know, it becomes a fire hazard? Is he unplugging a lot of electrical things in the home, which is not uncommon either, but it creates potential problems? Is he, we see this, you know, throwing all the food away in the home because he has contamination delusions that he won't eat the food because he's afraid it's been tainted? You know, is he putting all that out? How disruptive is he? One of the things is, I always give the example, and forgive the example, but I think you'll get my point. People are not always going to say they want to harm themselves or they want to harm other people. Most often, the nuance is for individuals struggling with mental health challenges who are going to get themselves harmed. And we know that's their harm to a much greater degree than they would ever harm anybody else. That, you know, misnomer out there in the community. I think of a gentleman walking down the street where children are playing, who is sexually preoccupied as a, you know, part of his mental illness, who maybe his pants are pretty low, or he's making sexual remarks, or perhaps, you know, racial remarks that sometimes manifests, where you can, you know, a lot of folks who are pretty impulsive are going to want him not to be there, right? And so how can we mitigate a situation like that, right? I also think about individuals living with, you know, it doesn't matter. Sometimes people think, well, it's only in this area of town. It's all over. If somebody's mentally ill and is getting up in the middle of the night because they're not sleeping and is walking in and out of the house and leaving the home open and exposed, right? And there's an elderly caregiver there who's also always not sleeping, because that's the assumption we need to make. If somebody is up and has impaired sleep cycle because of their illness, their loved ones aren't sleeping, right? How can we have an opportunity to mitigate that event, to offer service delivery? Our coming out, Joseph, allows us to say, you know, it sounds like at this point, what we're seeing is not enough to, you know, we asked him to come with us to the hospital. We asked him to come see our psychiatrist. He unilaterally said no to both of those options. We don't at this juncture have enough to facilitate writing out a probate or having it pass through probate court. But if this continues to escalate, you know, then we're going to be in touch with you over the course of the next week or two, touching base just to see how things are progressing. Sometimes it's I guess what we've learned is it's really rare for a psychiatric episode to just ameliorate all on its own. Most often it continues to become more problematic, right? When things do ameliorate all on their own, a lot of times we're looking at something that's in part at least substance induced. That doesn't mean it's not important. It just means, you know, that's something else. So that's what I would recommend.
If I could, thank you for that response, Jane. And if I could ask a question of both of you that was kind of on my mind throughout the creation of this presentation is, we know that when, for those of us on this call that have family members who have mental illness, we know that our fear and trauma responses can be activated when our loved one's in a crisis. So we may be panic stricken, we may be in shock when we're not sure where to turn. Obviously the initial reaction might be to call 911, but part of why we're doing this is to know that there are other options, whether it's hospitalization, accompanying a loved one to a psychiatric emergency room, or calling mobile crisis and waiting for them to arrive. Are there any words of advice or reassurance that you might offer to those family members among us? What can we expect, and what should we be aware of if the situation ever arises that we need to take these steps with our loved one?
I'm happy to respond, but I don't want to hog the
Maybe I
mic.
can hear from both of you, talk about your perspective.
Sure.
I
I think that our crisis workers we have a range of individuals working on our team. We have people just graduated from their bachelor's with their bachelor's in social work, right, who are not licensed. We have a bunch of crisis call takers who don't have a license, all the way up to people with their independent licensure, meaning they've gone to grad school and have at least 2 years. We have about 5 people on the team who've been here close to 20 plus years or over. That doesn't include all of our supervisors. There is a sophistication to being able to accept a call from a loved one and provide not just a service and guidance for the person they're calling about, but to see them as part of the client system too, because we are our loved ones. If we're their advocates in a moment of crisis, of course we're triggered, right? I have family members as well, I can be both in this role, but I also want to have the worldview of what would it be like. I ask our staff all the time, if you're calling, you had to call us about your sister or your mother or your husband, what kind of response do you want? And first, do no harm, non-judgmental, empathic to the highest degree possible, and trying to be very honest. I think this is huge. Honest about what is in our capacity and what is beyond our capacity, what mobile crisis team can affect, what change we can affect, or what options we have, and what is beyond what we can do. Because I think everybody appreciates honesty, right? And at that moment of your own triggered, anxiety and wanting to make sure your loved one is dealt with respectfully as well as safely, right? I want to try to honor that to the highest degree possible and say that this is how we see the work we do.
Jane, that was great. I mean, I think I would add to that. Just remember, who's in front of you. I mean, that is somebody who you love, who you care about, who's scared, and who really needs help. I would say, I would also say, just think about your own safety. Think about your own, Matt, you talked about trauma response. Obviously, if people are triggered and this is uncomfortable, make sure there's a plan. Make sure there's a plan. Talk about it as a family to the extent you can talk about it as a family. And even if that person is unwilling to engage in that, because we know some people just it's a part of their illness to just not see that they have an illness. And what the family can do is band together versus kind of fracture apart and come up with a plan. How do we work together? How do we support one another when this happens? And how do we help keep our loved ones safe? But that remember, stay calm, have a plan, and just really keep in mind that is, even if they're angry and aggressive, there's usually they're scared in my experience. There's something that's going on there. And I always tell people in terms of myself too, I always want to be curious, just try to be curious and try to find, how can I help you? What's going on? What do you need? Right. And really kind of tap into those things, those human elements that we know we would all want if we were in that situation as well. I can give you a lot of don'ts, but I think that's the stuff to sort of focus on. But yeah, we don't want to argue. We don't want to kind of meet their aggression with aggression. And Jane, that was great. You have to be honest. If people know you're trying to dupe them, like, that's going to make them even angrier. So, but that's where planning comes into play. That's where working together, really does come into play.
I'll just say, I actually I'm not saying pointing out that I have to leave or anything, but I go into CIT training with police officers at 1 o'clock. Crisis intervention team trainers, a representative from St. Vincent's and myself meet with them every 2 weeks for all the new training groups. That's one of the important things I tell the officers, because people rely on what they think they believe will work. And I will say, you may not realize this from prior experience, but somebody can be exceedingly psychotic, telling you having some grandiose delusion, or their thought process is not linear and it's word salad. What they're saying, they're jumping from topic to topic. It seems, unrelated. That doesn't mean they don't know when you're telling the truth. So when you try to engage them and say, oh, I hear that voice too, it's telling me to tell you to get in the car, or, and I'm not saying that's a common example, but right, if you're very close to getting somebody to get into the back of your squad car to be conveyed to an emergency room, right? Don't say to them, we're just going to go for a cup of coffee. I'll say, because you know what, that person's going to turn foot so quickly and you've lost anything you built with them, albeit superficially, because they know exactly that you're lying and they know that you more so don't respect them, right? Even in the midst of acute psychosis, people can tell. And that's, and to Mike's comment, we're all people.
Thank you. Yeah, thank you both for answering that question. It looks like we are almost out of time. So at this juncture, I would just like to point everyone to the chat box where I have placed the link to the evaluation for this presentation. I'd love it if everybody could right now click that link and open that up in your browser and take 1 to 2 minutes to complete it. It's anonymous. We appreciate your honest feedback, really helpful for us to get a full picture of how this webinar was received by all of you, getting a lot of nice comments in the chat from our participants that this was a great presentation. Glad you feel that way. Definitely complete the eval, would love that. Thank you to Jane Granzier and Dr. Michael Biscaro for their generous donation of their time today and educating NAMI audiences on a very important topic for Cuyahoga County. So I will also be sending a follow-up email to those of you that attended with a link to the slides, and hope you all have a wonderful rest of your day.
Thanks,
Thank you so
Matt.
much.
Thanks, everyone.